The first of the musculoskeletal conditions I want us to look at is congenital hip dysplasia. And in congenital hip dysplasia, the hip, or the femur, is out of the socket. Instead of being in the ball and socket joint this way, it's up and out of the socket. So this way the leg is going to look shorter, and we're going to see extra wrinkles. So let me show you on this baby here. If the hip is up and out of the socket, the leg looks shorter. So you can see that there's extra wrinkles in here, extra gluteal folds. If you turn the baby over and you look and bend their knees up, the one that is affected will be shorter because it's out of the socket, and it's going to look much shorter. Another test that we do is to try and put the baby's knees down to the table. Babies can do something that you and I cannot do. These knees can go just about, if you pull it sideways, just about to the table. If the child has a congenital hip dysplasia, it won't go all the way to the edge of the table. You can move it only slightly, and you'll hear a grating. It's called Ortolani's click, with this grating sound. So you can see in the picture also the things that we just demonstrated. You can see the extra gluteal folds, you can see the shortened knee, and you can also see that you cannot put that leg all the way down to the table. Now, if a child has congenital hip dysplasia, the treatment is going to be to abduct. So abduction, remember, is turning away, absent. So one of the things that can be done is this pillow splint. They can also be put in a cast. If it's relatively minor, sometimes they'll use double or triple diapers on the baby. I would caution you, however, if you think the child has it and you hear that Ortolani's click or that grating sound, please don't keep doing that over again. That's not good for the baby's hip. Most children with hip dysplasia, if treated early, will end up doing quite well. Another problem we want to look at is club foot, talipes equinovarus, or club foot. Now, most babies when they're born have a little bit of club foot. Usually this straightens out pretty much as they grow a little bit. In some children this does not straighten out, and so their feet are still, the little toes are toed right inward like this. This interferes a lot with walking. So we need to straighten out those feet. And to do this, frequently plaster casts are applied. So if we look at the plaster casts, usually they'll change the cast every week, and each week they evert the cast a little bit further than it was the week before. Sometimes a Dennis Brown splint is used, and in the picture you can see that. If you look carefully, you can see the wig nuts just underneath those little shoes. And so when the child is napping, when they're sleeping at night, you can put the feet in there, and each week they can just evert the feet a little more and a little more. This could be used for any age child, even infants, but frequently it's used for children who have begun to walk so that we don't have to cast them and take away their walking skills during this time. Most children with clubfoot treated this way do quite well. Occasionally it's so serious they need to do surgery on the tendons in the back of the foot. Another musculoskeletal problem I want us to take a look at is scoliosis. The first thing they're likely to ask you about scoliosis is what age, and this is going to be probably somewhere between 10 years and 15 years when we do screening for it. So from maybe 5th grade to 10th grade is when we do the scoliosis screening. And remember, it's more common in girls than boys. Typically, the school nurse will ask the girls to come to school, maybe wearing a bathing suit under their clothes. And then they come into the nurse's office, and we ask them to bend over. And if you look at the picture, you can see as they bend over that and hang their hands down. I sometimes call it like an elephant doing the elephant walk here. What we're looking for is to see if those shoulders are even. And in the picture up here, I'll show you that in just a moment. Up here you can see that these shoulders are not even. Look at that. Those shoulders are nowhere near even. And neither are the hips here. Whoa, you can see that the hips are not straight across. It's not even. We've got uneven hips and uneven shoulders. These are characteristic findings in someone with scoliosis. If the scoliosis was simply functional, they had poor posture, when they bend over like that, it would disappear. If it's structural, it doesn't. We see these structural changes here. The treatment, if someone has scoliosis, first off, the nurse refers them to medical treatment, to the physician. After that, if the scoliosis is severe enough, then what happens is they may be put in some type of a brace. Now, the Milwaukee brace is a brace that actually pretty much goes from just below the chin to down over the buttocks area. And this is going to be worn 23 hours a day for usually about 3 years. There are some other brand names of braces and jackets that are used, but the principle is still the same. It keeps the spine very straight, and it's worn, as I said, 23 hours a day, off only for bathing. And this at a time when the adolescent, pre-adolescent or adolescent is very concerned about body image. So you might indeed see some questions about body image in a child with scoliosis. There are some other treatments. We can treat scoliosis with a spinal fusion. They actually put rods down either side of the spine and then fuse that. So, and they're going to be in a body cast. And they'll be in a body cast for 6 months, at least, probably, after the surgery with the Harrington rods with that. So expect questions on scoliosis that might also relate, as I mentioned, to the whole body image piece. Because it's a very difficult time for these little adolescent girls primarily.